has lectured both nationally and internationally. He is an excellent speaker and an excellent clinician, and today we are lucky to have him to share his expertise with us on vital pulp therapy. So without further ado, Dr. Moreno.
Okay, thank you so much, Christina. I just need someone to give me the thumbs up that you're seeing my screen properly, the slide. And
you're good to go, Jorge. You're good.
Okay. And also you can hear me properly, right?
Loud and clear.
Okay, great. So let me just see if I can just remove this here. Okay. Okay, well, it's around 11:06 in Canada. So thank you everybody for attending wherever you are. I think this is a great opportunity for everybody to connect in these very unsettled times. And I want to thank you. I want to thank Dr. Shergin and the Dentistry Academy for putting all these lectures and webinars together. This really keeps our mind busy where they should be at the most at this time. And it's also a great opportunity to share just little things that we do clinically. And every time that we go to these webinars, we always learn something. So I find them very valuable. At the same time, it also helps us to keep us in shape. I particularly keep going to the office. Being an endodontist, I see emergencies almost on a daily basis. And as someone was discussing before, I think the standard of care now that we can provide for patients with emergencies is not only the emergency treatment, but if we can provide also at the same appointment some more definite treatment, it will be helpful. We've been providing Tele Dentistry since this crisis started, and most patients were screened over the phone and prescribed with medications. But as you know, the antibiotics and the pain medication will only work for endodontic cases for a couple of weeks or a few weeks, and then they will return. So we're starting to see those patients coming back now, and we're glad that we can provide the treatments. Not only endo, we're also doing oral surgery emergencies at our office. We have also an oral surgeon that is helping us with a lot of extractions and emergencies that the patient require services from an oral surgeon. And interestingly, this topic that we were going to be sharing today, vital pulp therapy, is something that I am doing more often now than I normally do in my practice. And so those are the things that actually keep me excited about giving this lecture, and hopefully sharing and giving you a couple of tips that you might share and also learn from you from your questions or your comments. So, vital pulp therapy, a conservative alternative treatment for permanent tooth. And now I wanted to call it conservative alternative treatment because everybody is talking now about conservative tapers and preparations and access cavities and ninja cavities and all these things in endo. But truly, I think that there is a very few aspects in endodontics that could be as conservative as keeping a tooth alive and keeping it functioning and keeping it healthy at the same time. And that's what we will be accomplishing with the vital pulp therapy. Just gonna keep checking my time here. Okay, my slide is not going. Okay, so now I am going to start in a different way today. I'm going to jump right into what I consider is going to be the core of this presentation. And I have different reasons to do that. Let me just see if I can just, okay. Yeah, I have different reasons to do that. But, well, basically, I have three reasons. I don't want to start to be rushing at the end of the presentation, trying to give you the information that I think you guys need to take from this lecture. At the same time, if I give you all the core of the information I want to share with you or the main topics, we can sort of dissect those topics as the presentation goes through. But also, I'd like you not to be late for the next presentation. Dr. Mansour will be presenting around 12, and I really am looking forward to that presentation too, and I don't want you guys to miss what I'm sure is going to be an excellent presentation for Dr. Aldo Mansour. So that's why I'm going to start presenting right away the main topics of this lecture. So when it comes to vital pulp therapy, there are many, many articles that you can find, and I selected just a few of them, and I'm going to discuss mainly 2 articles, and this is the number one. At the end of the presentation, I might share another one. For most of the other research that I will be showing is going to be just mention it, but I'm not going to go into the details because of the time limitations. Is everybody doing okay so far? Like, can you hear me properly? I just don't see anybody on my screen, so I am a little lost. I don't know if I am.
We can hear you loud and clear.
Okay, perfect. Thank you so much. Now, let me just start with some. Okay, I'm gonna have to use my different mouse here. I have to close this. Okay, so some of the concepts I am going to be putting to your consideration are going to be in this slide. And the first one is the extent of the pulpal degeneration cannot be demonstrated by the signs and symptoms. So every time that we have a patient that comes with pain, and then he relates the type of pain, they are telling us, we have an idea of what type of situation could the patient be suffering, but we cannot demonstrate that. We cannot be sure if this is an irreversible pulpitis or reversible pulpitis. Even if we do the testing, and I'm going to show you at the end part of this article that actually shows why this is not always that conclusive. So this is the first concept that I'd like to share with you guys today. The extent of the pulpal degeneration cannot be demonstrated by the signs and symptoms that the patient has. Therefore, with regards to vital pulp therapy, the final treatment decision should be taken after the total caries removal and close examination of the deepest part of the dentin and exposed pulp are observed. This is another big information that we're getting from this article. We may have some concepts of IPC that I might not be even touching in detail today, but not until we remove all that decay, we'll not be able and see the actual pulp tissue. Not until that time we will have a good rationale to make the next decision as to whether should I grab a file and do a pulpectomy, or should I continue to be conservative and try to preserve that pulp. Obviously, this is a decayed tooth that we consider that is still vital. We're not talking anything that is chronic here with abscesses or sinus tract. This is a tooth which is a permanent tooth with a large decay, but that is still vital. Another concept that I would like to share with you guys today is the most apical tissue is usually healthy and it's amenable to preservation, which means that we need to protect that tissue that is deeper in the pulp chamber or inside the pulp canal systems. And again, later during the presentation, I will be sharing some information that will reinforce this concept. The terms reversible and irreversible refers to condition of only a portion of the dental pulp. And that's why even our testing cannot be conclusively considered to determine the full treatment when it comes to vital pulp therapy. And this is another very important that is related with also the second topic that I mentioned, and it says direct examination will complement the pre-op diagnosis that we have and will provide with a more predictable treatment, which means that we need to be careful when we're removing the decay, remove it all, and then remove the tissue, the soft tissue that we consider is either infected or inflamed. But to do that, we have to have a direct examination, and magnification will be crucial. You must have magnification to do this. And yes, if you have powerful loupes, those might work, but ideally, this is much better done under the operating microscope. So those are the concepts that I would like to elaborate a little bit more. And as we are elaborating during the lecture, hopefully this will be more clear. So just some points that we'll be discussing, some principles of vital pulp therapy, techniques and materials that we are currently using. And at this point, I'm going to apologize in advance because I was trying to upload a video and it actually crashed my presentation. So I just decided not to put it. So I'm probably losing one or two videos or pictures, but I will let you know enough information so you get the message that I want to send across. I'm also going to be talking at the end of new evidence of use this vital pulp therapy for treatment options, and some final remarks, and hopefully we'll have some time for some questions at the end of the presentation. So if I can have an agreement on these two topics that are on this slide, I think we will have a good core to start this conversation. If the prevention of the apical periodontitis is the ultimate goal of endodontics, keeping that pulp alive, that tooth alive, makes absolutely clinical sense. Absolute clinical sense. If what we're looking, the goal of endodontics is to keep the periapical tissues healthy, there is nothing that can do that better than a vital tooth. So that's why it is important to do this or to consider this technique. The second paragraph is saying under normal circumstances, healthy tissues respond better than inflamed tissues. I think that makes a lot of sense, and should even respond better than infected tissues. And I said under normal circumstances because it might be different if the patient has an immunocompromised disease that might affect his response. But under normal circumstances, when we are dealing with a healthy tissue, we normally get better results. And when you do the root canal treatment on a vital tooth, that you decide that is the root canal is the way to go, is shown by hundreds of articles that the prognosis will be much more predictable and the outcome more favorable than if you do the same root canal on an infected tooth. So those are the concepts that we're going to be applying to vital pulp therapy. From the undergrad times when we were in dental school, we were told that reversible pulpitis is different than irreversible pulpitis in the way that the reversible pulpitis is normally a sharp pain compared to the other normal teeth, very short duration and subsides quickly. Whereas when the situation turns into irreversible pulpitis, the pain becomes much more difficult to diagnose. Normally the C fibers are more involved. In this case, it's a dull throbbing or even radiating pain. And normally it lingers when we stimulate that nerve. It's affected by temperature. Quite often the patient can alleviate the pain with the cold rather than the heat. And you might see the patient coming with a bottle of water to alleviate the pain. That's a true emergency. And we have seen a few of those during this time. Also, the tooth may have some pain to a percussion or bite. So let's keep this in mind, because these two situations that we know from clinical testing might not be represented totally or truly when we are dealing with vital pulp therapy concepts. The transition from reversible to irreversible status is only clinically interpreted. We are assuming if a tooth is reversible or is irreversible, but we don't know when it's actually determined histologically. We don't know that fine line when a tooth will be able to recover and not recover. So that's why knowing a little bit of the histology will let us have more clinical judgment that will be closer, that will put us closer to determine whether that pulp or that pain or that inflammation in that tooth is reversible or not. So let's keep those concepts in mind, and then we can elaborate more a little later when we disclose the details of the study that I showed you at the beginning. This is another concept that I guess you are aware of this. The vital pulp therapy is one of the treatment modalities with more controversy in endodontics. And this has been for at least 60, 70 years. You can find articles, classic articles from the 60s or 70s, perhaps. This pulpotomy was probably in the 70s when it was first introduced. And it's been always reconsidered and revisited, and you will find a lot of information, both in favor or against this. So my goal today is to show you one of those alternatives that, in my humble opinion, might help you to favor a vital pulp therapy treatment. So we know for fact that teeth like this that come, let's say, with what we consider to be reversible pulpitis, we feel pretty comfortable doing the treatments, and we know about files and tapers and anatomy and canals and CBCTs and you name it. We are getting this information on a daily basis, but we don't get as much information when it comes to vital pulp therapy. Now this, as we know, when everything goes well, pulpectomy, endodontic, conventional endodontic treatment could be quite successful. In this particular case, I was able to follow this case for 6 years as the patient returned. The 6 years follow-up is for the second lower molar, for the first lower molar. I'm not using the tooth nomenclature that we use in Canada because I don't know where the audience or how the audience are managing the numbers, but the first lower molar was completed more than 6 years ago. The patient returned about 5 years later to have the endodontic completed in the second lower right molar. And again, after 6 years, you see what we consider to be healthy tissues. And when everything goes like this, everybody is happy. The restorative dentist is happy providing crowns for this tooth or for these teeth. We are happy that the treatment is going well and is actually being successful. But this is not the case all the times. And you and I know this. And you and I know that even if we see the canals in a cone beam CT scan, it doesn't mean we're going to find it. Even if we find them, it doesn't mean we're going to go to the apex. And even if we go to the apex, it doesn't mean we can clean the canal entirely. So there are still a very like a good number of variables that we don't have that much or total control on those, right? So that's why if we keep that tooth vital, perhaps we will have better control of those periapical tissues. So the controversy is, should I, on a case like this, do a root canal or do something different? So let me just show you this here. This is another case on the top. Tooth on the lower left, heavily decayed, and this tooth came for a second opinion because the patient it was decided, I think it was a young patient, and they were thinking about extracting the tooth. They were not sure. They came for a second opinion. That's the way the tooth looked clinically, so heavily decayed, gingival tissue growing inside, all contaminated. I didn't have that much hope either when I saw this tooth, but I said, okay, let me just rebuild the tooth. We put an orthodontic band, and then I was very careful removing the pulp tissue and the decay. As you can tell from the X-ray on the left, this is a young patient. I think it was probably 13, 14 years old. I don't remember, but I remember it was a young patient. So this is as I completed the case with the ortho band. That's how I hand the case to the referring dentist. This case was particularly completed with biodentin, which on the radiograph, it has a little density, the density very similar to the actual or natural dentin. I normally follow these cases in 3 months, 6 months, 1 year, and 2 years. So this X-ray on the upper right is probably at the 3 months time. And then the next one that I have here was, I don't know, probably a year or 3 years later. So there you go. And then the tooth, it's got a better restoration now and it's totally functioning. So again, 2 different approaches, similar results. One tooth, it still has some vital tissue inside, it's functioning properly. But listen, I was dealing with a patient that was a very young patient. I don't see kids in my practice, but sometimes I have to deal with very young patients. And if I can provide a treatment that is a little faster, much easier to do, and provide me with consistent or reliable results, that's, I think, is a very good clinical decision or treatment option that I have. So in all school days, when we use the classical textbooks, we are given some information or concepts about vital pulp therapy, and that's why this should be in brackets here. These classic concepts like these are suitable for only limited or to young patients and patients that are very well motivated to follow up with the treatments. That's one of the reasons they are in some of these textbooks. expressing that where the vital pulp therapy might be indicated. It only works in immature apex and mechanic exposure. It is more predictable if the tooth is asymptomatic, and you probably shouldn't have any pulp stones. Those are just a few of the concepts that you can get from these classic textbooks. But when you start looking at the literature, more recent literature and the research more in depth, you start looking at different papers, different opinions. Like in this particular one, I'm gonna let you know the reference in a second. It says vital pulp therapy is being adopted more frequently and is considered a viable alternative to the root canal therapy in the short term. That's one of the conclusions from this article. MTA partial pulpotomy, which is vital pulp therapy, can be considered appropriate long-term management for symptomatic carious exposure of mature teeth with plus 80% success rate after 2 years. That is a little against of those topics that we get from the classic textbooks. But again, you need to look into the literature and again, see what is the level of evidence that these papers are giving you. But just to show you that this is from the Journal of Endodontics from September of a couple of years ago. Even the American Association of Endodontists, they have some recommendations in their website. And I personally find it very, very vague. I think that from an association like the American Association of Endodontists, they should have more robust information in their website. They're saying indications for pulpotomy, primary teeth. It seems that they favor the primary teeth, but we know that it works well, but they are not giving that much importance to how efficient this could be in permanent dentition. For the permanent dentitions, pulpotomy, they are only saying that it might be good for as an emergency procedure, and pulpal debridement should be encouraged. So they are saying basically pulpotomies don't work in the long term. That's what they are implying here. When it comes to direct pulp capping, they are saying that all the following clinical conditions should be present, that the exposure should be mechanical, that the bleeding should be easily controlled, that the material should be in intimate contact with the pulp tissue. Some information that I will say, yeah, most of this is valid, but I don't think it's given the value as for this treatment to be the true alternative as it is to treat deep carious conditions in permanent teeth. It was with a purpose that I didn't highlight the indirect pulp capping because I'm not going to be discussing indirect pulp capping, and probably you will understand why in a couple of slides. These concepts that I just expressed that are in the A also are challenged by other type of articles. Like this is a very good article that is telling us they did a systematic review in teeth that were deep decay with exposed pulp, and all these teeth were permanent. And they were saying here that partial pulpotomy and full pulpotomy provide a more predictable outcome than direct pulp capping. They are saying all of them work, but those with full pulpotomy and partial pulpotomy work a little better than direct pulp capping. And I think this goes back to one of the basic concepts we discussed at the beginning when we say a healthy tissue will respond better than an inflamed tissue, and much, much better than an infected tissue. If we remove the pulp that is affected, perhaps it's going to give us a better outcome. That's why this article is telling us that partial and full pulpotomies have a better success rate or more predictable than direct pulp capping, because in direct pulp capping, we're actually not seeing the pulp tissues how they in its entirety in the entire surface as we can do with the pulpotomies. Another conclusion that we have from the same article: success rate of the direct pulp capping was observed to fluctuate. In contrast, partial pulpotomy and full pulpotomy did always have a good success rate for 3 years or more. And in this case, it wasn't just young permanent teeth like the cases I showed you before. These are patients that were ranging from up to 70 years old. Just gonna skip on this because I really don't want to go behind on this. This is Journal of Endodontics from 2011. And this is the same article. This is the article I showed at the beginning. So we're gonna start dissecting now that information that I gave you in the first or second slide. So in this particular study, which I consider a very aggressive and very, very important study, they actually studied more than 1,000 teeth. More than 200 of those teeth were extracted and then analyzed histologically, all these teeth somehow were treated with any of the viral pulp therapy's treatment alternatives. The remaining, the vast majority, were cases that they were following, and some of those cases they were able to follow for up to 30 years. So I think it's a very serious follow-ups that they had here. When it came to reversible pulpitis, they only, when it came to direct pulp capping, they only use calcium hydroxide, and also only they selected for direct pulp cappings only cases that were reversible inflame. And they tried to establish the success or the results from both radiographic findings, clinical findings, but also from the histological assessment or histology assessment of those extracted teeth. And that's what this article is going to make a difference, or is going to give us something that we need to rely on. And this is probably the most important slide that I will show you today. This picture on the upper left, it doesn't belong to the article, but I think it relates with what you see in the histology samples here. And what it is a decay that we know, if we can relate with this molar here. You see this area, which is the closest one to the decay lesion, that's when the pulp becomes necrotic. And that's an irreversible damage of that area. And what you see white there, those are micro abscesses. But right below that area, there is a high concentration of inflammatory cells. And inflammation, as you know, is a defense mechanism of the body. So we cannot say that inflammation is that bad. It may help us, but even further underneath that inflammatory cell site or area, you will see normal vital tissue. And I put vital in brackets. You see tissue that histologically will look more normal. And that's, for a big decay like the one you see here, that's quite the amount of healthy tissue that is going to extend into the roots and is going to provide us that reservoir of healthy tissue that will probably help us obtaining a good result with viral pulp therapy. Now, if you can use the same picture here, the same histologic samples, and you can imagine that we do a direct pulp capping. Obviously, we're going to leave all these abscesses behind. So that's why direct pulp capping is not widely accepted in the endodontics field, because it's very unpredictable. You don't know. And as I showed you at the beginning, we make the assumption that a healthy tissue should heal better than a tissue that is inflamed, or even much better than a tissue that is infected. So if you do an IPC here, very likely it's not going to work the same as if you remove the entire both infected and inflamed tissue. And if you can see with your eyes, with your magnification, tissue with the characteristics that I will explain you in a few slides, then you might be in a better position to save this pulp, keep this tooth alive. The vast majority of the radicular pulp is still vital. And these changes may happen in the absence of symptoms. Most of some findings of this study, they realized that the patient didn't have any symptoms, and yet they had the degeneration of the nerve like this. That's why in my earlier slide, we were saying, okay, this doesn't always relate what the results I get from the testing with what is happening histologically. So this is probably the core slide for the concepts that we are sharing or discussing today. And this is from Rikushi, and I will give you the full reference a little later. These are exactly the same findings that I disclosed in my first slide. Extent of the pulpal degeneration cannot be demonstrated by the signs and symptoms. They found that when they analyzed these histologic samples. With regards to the viral pulp therapy, final treatment decision should be taken off after total carious removal and close examination of the pulp is possible. And the most apical pulp tissue within the roots is usually uninflamed and is probably favorable to provide healing. And the other one that I have highlighted here is the direct examination of the pulp tissues is fundamental for the treatment plan decision. In other words, you have some information from the pulp testing, you have some information from the patient's symptoms, and you assume a diagnosis, but you're not 100% sure until you enter and see if you can see signs of infection, inflammation, or signs of healthy pulp. So those are the main messages that this article is giving us. In this particular study, pulpotomies range from 77 to 96% of the cases, and direct pulp capping was somehow better in their 73% of the cases. Now, this is a different article by Dr. Martin Trop, which is a very, very active in this type of topic as well. And he's giving us the conditions that we need to have to consider, okay, this tooth, now we see the pulp is sort of healthy. We see some potential for it to heal. So we need to make sure that that pulp is minimally or non-inflamed. That's why removing that necrotic pulp tissue at the surface is very important. The bleeding is properly controlled, which means after the light pressure with diluted hypochlorite with a sterile cotton pellet, it will be gone in 1 to 3 minutes. And then we need to put a cap on the, cover that material, and then make sure that there is no leakage after we do this under rubber dam isolation. And this is from the Endodontic Topics journal, which is no longer in circulation, but it's always in the libraries online from 2003. And this is the graphics that Dr. Trop and his colleagues used just to show us the zone that was showing before with the micro abscesses, the inflammation right below, and the normal pulp within the tissues, and how this has to be very tightly sealed so for us to help that tissue promoting healing. So let's start talking about pulpotomy, because among the vital pulp therapies, pulpotomy is the one that is going to give us the highest success. So if you need to bias between indirect pulp capping, direct pulp capping, and pulpotomy, bias to pulpotomy. And this is going to show you why. Because the pictures on the right side, which is the same study from Rikushi, will show you some dark areas. This is not the same tooth. These are different teeth. But this is what the situations where you probably will consider doing a pulpotomy, removing the nerve. If you see some sign of necrosis, which is represented in this section in A by the dark nerve, the darkest appearance of the dentin. Or if you start seeing some sort of pulp stones in the middle, if you start to see some sort of fluid inside the pulp chamber, then it's time to take that round diamond and remove new round diamond and remove that tissue at the surface until we get something like we see here on the bottom right, that you can see tissue, that the bleeding is stopped, totally surrounded by healthy dentin. There is no decay there. We're not playing with IPCs here. And those are probably the situations where you're going to say, okay, I am ready to put the material. I think this tooth is going to work. You were able to see the tissue with the magnification. You were able to stop the bleeding. So just to give you some more, and I'm going to go quick through this again because I don't want to be late. This study, which is from 2017, also pulpotomy is a reliable treatment option for the treatment of symptomatic apical periodontitis. In this particular one, it was questioned, I remember when this article came out, because they are saying that all the pulpotomies in this particular study, so they had a 100% success rate, which some people were a little bit suspicious about it. This is a different article, but the same Journal of Dentistry, where they evaluated pulp exposures in permanent teeth, and they did a systematic review. And you probably should read only the bottom part of the slide, the success of pulpotomy in managing irreversible pulpitis in permanent teeth. It was challenging the concepts that we had about the irreversible status of teeth that were considered irreversible, inflamed because of the symptoms or the pulp testing that we did. So another study that supports what we were saying. Direct pulp capping, as I said, success rate is not as high, perhaps because we don't know exactly where the healthy pulp tissue is starting, but it's still a very good option. If the inflamed pulp is capped, the success will not be as predictable as we have with the pulpotomies. If the inflammation of the pulp is related to carious invasion, there is very likely bacterial invasion of the pulp tissues. And if you see a picture here, again, from the same study from Rikushi, you can tell that if this was during the decay removal, very likely that tissue at the bottom will have some sort of infection or at least bacteria invasion. So some requires to look for, if you decide to do the direct pulp capping instead of the pulpotomy, you should be surrounded, or the pulp tissue should be surrounded by healthy dentin. You should see a very even layer of the pulp tissue, the most outer surface of the pulp tissue. You don't want to see any pulp stones or any dentinal chips within that tissue. And again, the bleeding should and must be controlled within 1 to 3 minutes. And they normally recommend doing it with chlorhexidine or diluted hypochlorite. I put here one because I think that's what the article mentioned, but there are many other articles that they also recommend 2 or 2.5 the concentration for hypochlorite with light pressure to stop the bleeding. Again, this is just to show some success rate for the direct pulp capping, 84% to 92. In this particular case, this is quite high, but all these cases were considered reversible. So the symptoms were not spontaneous, were not the typical symptoms that make a patient go to the office on an emergency basis. And therefore, those are higher results with the DPC. So let's talk about just a few minutes to talk about the materials, and this is where I'm going to be missing a couple of my pictures, sorry. And the first one and the most common use for decades is calcium hydroxide. It's been traditionally the material of choice for, or the most widely used up until probably the last 2 decades, that other materials were introduced in the market. It's antibacterial and disinfects because of the high pH mainly, but it's very unstable, especially in the long term. It washes out in the presence of moisture and tends to be very unstable in the long term. A major disadvantage is that they do not seal the exposed pulp from the external environment. They always remain, even if you put the dical, it's not providing the seal that we require, as I mentioned before with the previous slides. It tends to be softened, so it might disintegrate, dissolve, or wash out in the presence of moisture. And this is from the International Endodontic Journal from 2010. A better material that probably you're very used to is the ProRoot MTA. And again, I'm not going to go into the details of the components, but it's a material that probably is one of the materials with most studies that you can find in the literature. Very well supported. And it's not a new material. People knew this material decades ago by the name of Portland cement, or they even call it concrete because it's a very similar chemical presentation, I guess, of formula with the concrete. And it's very, some of the concerns with this material that I'm pretty sure most of you know is the manipulation when you're mixing it, because it's not that precise. There is a lot of waste in the envelopes because they are selling the envelopes for single use, and mainly there is discoloration associated with the gray or the white MTA. Setting time is quite long as well, so you normally have to do these treatments in 2 appointments. But in terms of success, when it's compared to calcium hydroxide, it's a much more stable material, and that will make it a material of choice on top of the calcium hydroxide. This is probably one of the discolorations that you notice. This is a case that we did with MTA, and you can see clearly how even white MTA in this case affects the aesthetics. The bioceramic is another material that is, the formula is very similar to MTA. All these materials are considered bioceramics, including the MTA. But this is the one that from Brasler, is called endosequence. It's very well tolerated. Its setting time is a little faster, and it comes actually in different presentations. What you see on the left here is the putty presentation. And what you see on the right is the fluid presentation, where you can use syringes to deposit it. On top of this, there is now the fast setting material, which is much faster. I think it will set in about 20 to 25 minutes. So it'll be much more, much faster. Minimum discoloration. I put this picture in the middle because you can see here how crumbly that material becomes with the time. You can use a little bit of the fluid one, or even the sealer that is named root canal sealer, bioceramic sealer, and make it more easy to manipulate. But very, very good material. This material has been also, has quite a few studies now saying that it's quite successful for partial pulpotomies. Biodentin is another material. This one doesn't come in a jar or in a syringe. This one comes in a capsule, like similar to an amalgam. And this is one of the pictures or videos that I lost. It's very, very simple to use. You just mix it for 30 minutes. The only problem is before you mix it, you need to put some drops of water inside the powder, inside the compule. And sometimes that leads to errors and the consistency of the material is not that easy to manipulate as the bioceramic. And also there is a lot of material in one capsule. So there is a lot of waste in this material, but it's very successful. So some concepts here about the pulp therapy on infected pulp, based on what we have said, is unlikely to be successful. So if we know this, please feel free to use your round diamond number 2 with a lot of irrigation, high speed, remove that surface of the pulp tissue. You might aim for a better result. And this is another concept from Dr. Trope. Vital pulp therapy on inflamed pulp is unpredictable, but usually offers good short-term results. And I like the term that he used. It's not uniformly successful, and I like that, and that's why I put it from this very good speaker. However, if you do it on a healthy pulp, so no signs, no symptoms, no inflammation, then that's going to be a little more successful. Okay. I think it's going to take me probably 5 more minutes to finish. So let me see. Minimally invasive, a new diagnostic system for assessing pulpitis and subsequent treatment needs. This is the second article that I mentioned at the beginning. I will like your attention on. This is from a couple of years ago. And this is an article where they are actually challenging the classification of the pulpal diseases that we have currently. And they have the evidence, including the Rikuchi's paper that I show you, to propose that. These are just some of the conclusions that I just put out for you. Highlights that there is a reversible inflamed tissue that sometimes is diagnosed as irreversible. This implies that the currently employed terminology might not reflect the actual inflammatory status of the pulp. Less invasive alternatives, strategies could be used to treat pulpitis, and less invasive alternatives means you don't need to take a file, you don't need to do a pulpectomy all the time. Please trust vital pulp therapy. And the technique that they are using is pretty similar to the one that I explained you in the paper or from the paper of Dr. Rikuchi. This one at the end, I want just to read it for you. Combining knowledge of pulp biology with an insight into why conventional therapies often fail stimulates a shift in thinking about endodontic treatment. So they are actually questioning the success rates studies that we have for conventional endodontic treatment, which is true. Anybody who has a cone-beam CT scan, you can see how much apical disease you can disclose on teeth that otherwise were considered healthy. So avoiding full could be the first step. This is not avoiding. This probably made a mistake when I wrote down here. What they are saying here is that aiming for full pulpotomy is probably the way to go when you want to compete in success against the success rate of conventional root canal treatments in teeth that are heavily decayed, but they are still vital. So sorry about that typo there. And this is from 2017. They call the endolight, that's the new way they call it, and it's basically a coronal pulpotomy that is a little shallower than the one that we consider when we do a SVEC pulpotomy or partial pulpotomy. And I'm just not going to go into these details because I think you guys know pretty much about this. Okay, so just a few cases to wrap up. I think I have a couple of minutes more here. These cases, sometimes they fail too. This is a case that came to me to treat this lower right molar. I did it with a gray MTA at that time. This is years ago. I don't use the gray MTA for years now. And this is my final result. But then the patient returned, and I guess that's the 1 month, no, that on the upper right is the 1 month follow-up, and then the patient returned within a year or so later saying that she was in pain, and then I had to do the root canal. So this is actually my final result. So the viral pulp therapy didn't work, but folks, should we call this a failure? This patient was asymptomatic for most of the time. When she started feeling the symptoms, she came back, they were mild symptoms because the tooth was necrotic. And then we provide the root canal treatment. So pulpotomies, viral pulp therapy actually helped keeping this tooth for a little longer until we got the treatment at a older age for this patient. But I don't consider this to be a total failure. Again, I might be probably biased because it was me who did it, but you guys may have a different opinion, and that's more than welcome. Another case, this is the x-ray that was sent to me by the dentist. This is the way the biodentin looks like. When you put it, and as I said, it comes in a capsule, in a compule that you deliver the same way you deliver GI. And this is the final result. This is a partial pulpotomy that we did on this tooth with that heavily decay. I think this probably is 3 or 6 months, and this should be probably a couple of years. You can tell by the development of the root apexes of the premolar, 2 years follow-up, and I think I should have another follow-up after that of a tooth that is working perfectly fine on a very young patient. So this is a summary for those who want to, follow like a flow chart of how to do it. It's a very easy, and I can email this to everybody or anybody who needs it. I'm going to put my email in the final slide. You can ask me for a copy of this, but the reason I put this is please concentrate on that's my timer just saying that I'm on time now. I'm about to finish. These green areas is basically what we need to aim for. Sound dentin, sound dentin. And if we have that sound dentin, it's normally that we can see it with magnification, then you may be in a better position to look for a better outcome. And sound dentin means obviously a sound pulp underneath or surrounded by this sound dentin. Okay, so I guess I'm wrapping up now. This is another case that we can see how not all the time when we see a case like this with this large apical radiolucency, it's not all the time that we need to jump and grab a file or do apexification and do all these things. We still don't know exactly what is the full capacity of the tissues, both inside and surrounding the tooth, that might help us healing in situations like this. This is a tooth, upper lateral, with, as you can tell, a sinus tract, apical periodontitis. We provided a minimum access, and then we did a different type of therapy here, trying to reinforce those walls. And people might call it revascularization. Again, that's for another a topic for another discussion. They might call it revascularization, regeneration. Root fortification is a very nice term that I've heard. And that's what we're trying to do, using that potential of those tissues within and surrounding the root. This is a few months, this is a couple of years after, and you can tell how from here to here is starting to get stronger roots and closing that apex that in the future, if it's needed, might probably give us the opportunity to do a more definite treatment. You can also see the dentinal bridge developing there. And I think this is the most recent x-ray that I have with almost total closure of the apex here compared to how it was. And this is how it looks clinically. And I think that's about it. I'm sorry, I'm probably a couple of minutes late. I hope I didn't rush too much, but this is my email. Please feel free to send me any question if I don't have the time or if I don't have the knowledge to respond at this time. And I again thank you for letting me share this information with you, and hopefully you can get one or two of these pieces of evidence to start applying in your private practices.
Perfect. Thank you so much. Yeah, thank you so much for that, Dr. Moreno. We really appreciate it. A couple of housekeeping items before Christina starts with the Q&A. If you haven't done so already, please make sure that you type in your name and your email address to the chat group. Also, this video will be uploaded on our Dentistry Academy YouTube page, so please feel free to watch it again if you would like. And as Dr. Moreno mentioned, he will be providing you with the lecture or the graphics if you would like. Jorge, there was just the images were a little bit pixelated, so we might have a couple of our viewers might ask for the presentation again, if that's okay, or at least some of the image or the...
no problem. Were they slides or were they pictures?
I think it was mainly the slides, but it was legible in a certain perspective. But if anybody needs or wants to see the presentation again...
I apologize. On my side, on my screen, they were looking fine, so I was not aware of this.
No problem at all. Another thing too, I just want to give a quick and a friendly reminder to tomorrow's talk on aesthetic treatment strategies. It will be by Dr. Pio Modi and Dr. Jeff Sumner and Eddie Corrales. So it's going to be a very, very good talk. We're looking forward to seeing you guys tomorrow at 11 a.m. And the password is track20, just as it has been in the past. So we're going to go ahead and have Christina come in and ask Dr. Moreno a couple of questions.
Hi, Dr. Moreno. Thank you so much. That was an amazing presentation.
Thank you.
We have some questions here. The first one is from Dolly. Is there any specific concentration for the chlorhexidine that you recommend?
Yes, that's a very good question. We normally use two different types of concentration for chlorhexidine in dentistry. One is for perio purposes, and the other one is for endodontic purposes. The one for endodontic purposes is the one that we use, is 2%. It's 2%. The other one is 0.12%, but I think that one is mainly for perio, so it would be up to 2%.
Okay, perfect. And the next question is from Lokesh. In a tooth with a diagnosis of pulpal necrosis, do you proceed without local anesthetic before treatment?
No, I don't. I all the time put the freezing. There are pressures, there are fluids inside the tooth that you might send beyond the constriction, and you don't want that patient to have that discomfort.
Perfect. There was a private question with the person asking if we can get a demo video.
I'm sorry, can you repeat it?
There is a private question asking if it's possible to get a demo video.
Yes, on the pulpotomy, yeah. If you can send me, I put my email at the end. Just let me know. I think it was a little too heavy for what I might have to edit it, and then I'll be happy to share any videos. And to be honest, I don't think my videos won't have the quality that you can get online. I might give you actually the links of a couple of videos that I know from clinicians that are very into the quality of images. And then I can also send mine along with some links for the other clinicians who have much better videos than mine, but I'm glad to share mine.
Awesome, thank you. The next one as well is private. Do you temper occlusion after you complete the pulpotomy procedure where patients have had severe symptoms?
Do I
temper occlusion? So I guess lighten the occlusion.
Oh yeah. Like that's normally I do it as a routine for any procedure. And I do it normally at the beginning. I just make them, when I'm building up, these teeth are normally heavily decayed. So these teeth very likely will require some crown. So I don't have any hesitation to put these teeth out of bite because that will certainly help the post-op discomfort.
Awesome. The next one as well is private. How can you be certain you have removed all the inflamed pulp tissue?
How can I'm just cutting off. You're cutting off.
No, sorry. How can you be certain that you have removed all of the inflamed pulp tissue? What will healthy remaining tissue look like clinically versus inflamed?
I can show you the picture again, or I can send the picture to whoever is asking this question. I'll be more than glad to do that. Basically, what you need when you remove the decay, you make sure that you remove the entire decay dentin. Then you're gonna have a lot of bleeding coming. Let's say a decent amount of bleeding. Don't hesitate if you see that bleeding. Keep on using the hypochlorite to try to stop it a little bit. As I said, it's diluted hypochlorite, and keep using a brand new round diamond number 2 or even bigger, and then go slowly, like 1 or 2 millimeters, and you will see if the tooth or if the pulp can recover, and you want that evidence, you will see this very bright red tissue that will stop bleeding very easily after you apply the pressure. Normally, it bleeds much, much more when you're taking the inflamed tissue or the necrotic tissue. It will bleed much more. If you see a lot of bleeding, then it means that you need to cut a little bit more. And listen, you're not doing anything wrong by cutting more. Even if you go full pulpotomies are quite successful as per the Ricucci study.
Perfect, thank you. The next one's private as well. What is your opinion of Theracal for indirect or direct pulp cap material?
If this is ferric sulfate, which I think it is by the name, there are materials. This is a material that I still use if it's the ferric sulfate, but is not as biocompatible as the MTA. So I will say, if you don't have any other alternative, I think it's still okay to use it. But if you can bias to MTA, bioceramic, or biodentin, much better. Which, by the way, you can use the MTA, the bioceramic, even in primary dentition, quite comfortably. Put it in a pulp chamber, it will work really well.
Perfect. The next one is from Dennis. In a failed vital pulp therapy, does it affect the success rate of the endodontic treatment after, if necessary?
Great question too. In my case, in my opinion, it shouldn't. Why? Because every case that I do with vital pulp therapy, I have a protocol to follow up. I see the patient 1 month, 3 months, 6 months, a year, and then a year after. The patient knows that at the moment they feel any symptoms, they call me back. And I need to do that because first I want to follow up on symptoms, but I also need to see that the tooth is properly restored. If I didn't restore it, if the dentist is providing the permanent restoration, I need that tooth not to leak. Remember the graphic I showed from Dr. Trope? Those teeth need to be properly sealed. If that tooth is to fail, I don't think you will have that much impact on the final outcome.
Perfect. The next one's from Nadia. Thanks for giving us some insights with the new EBP concepts. Would you please share some relevant references?
Yes, absolutely. All the slides that I show, the studies, if you look on the lower right, that's the reference. If it is not clear enough, I do have all the articles. Actually, I put just a folder with just the articles and some few more for this lecture. I'd be happy to share it. No problem.
That'd be awesome. That'd be awesome. And the next one's from Lokesh. What's your step-by-step protocol for partial and full pulpotomy? Okay,
so as I said before, good freezing technique, isolation, no leakage whatsoever from the rubber dam or through the rubber dam, and then decay first. Go ahead, remove the entire decay. Again, I am not a fan and I don't practice it. I don't do IPCs. That's why I don't talk too much in favor of that. But remove the entire decay. That will help you multiple purposes. Reduce the contamination into the pulp chamber, but also see if that tooth is restorable. Once you do that, then you need to deal with the bleeding as from the previous question. And the first, feel free to use the burr to remove that surface of the tissue that we know is necrotic and those 1 millimeter or 2 below it that we know is inflamed as per the histology. And then stop, light pressure, hypochlorite or chlorhexidine, and then go from there. Normally it's the stop of the bleeding and you can see the tissue. You see the tissue actually moving. If you poke the tissue, you can see the pulp there. It's not just fluid, it's not just blood. If you see just blood, it's not going to work. You need to see solid tissue, and the bleeding control within maximum 3 minutes will be a good sign to know that it's working well.
Awesome, thank you. We have a couple more questions about Theracal, which you've answered. And then someone asked about Neo-MTA as well with respect to direct pulp capping.
Sorry, what is that?
Neo-MTA.
Okay, so the MTA, after I guess the patent was released, there are many formulas of MTA. The only one that I'm a little concerned about is the MTA that is used for sealer for Gala-Perka points, because the MTA in those particular sealers, it comes combined with some resin, and it affects, is not pure MTA. Other than that, any MTA that you use should be fine. Should be fine. I normally use the most common one, which is the Pro Root, but I wish I had any financial support from Dentsply. I don't have it. But I use it because it's very consistent. What I don't like about that one is again how you manipulate it and how you deliver it.
Okay, We have a few more questions. In regards to the one about the demo video, they messaged again and they said that you mentioned a recording for the demonstration of the actual clinical procedure with material recommendations. That's what they were talking about.
Yeah. Just please at the end of the slides, that's my email. Please feel free that you, And if I cannot upload mine, if it's too heavy, again, I'm going to give you the link of 1 or 2 videos that I know are very useful. And those are public domain. We are not invading anybody's or taking anybody's work for that.
Perfect. So we do have a few more questions, but with time and this, we're only going to ask one more. So if anyone has any other questions, you can email Dr. Moreno directly. The last question is also private. Is patient compliance taken into account when treatment planning for vital pulp therapy, since follow-ups are imperative?
Yes. And that's a very good question. And when I show the textbooks, the old textbooks, or I shouldn't say old, but classic textbooks, they said that you need to feel that this patient is compliant. Because if it is not compliant and for any reason your results didn't go well, then this follow-up protocol that I just mentioned before will be of no value. Yes, patient's compliance, which in young permanent teeth, you normally get the parents to be compliant more than the child if it's a very young patient. But yes, it's very important.
Perfect. Thank you, Dr. Moreno.
You're very welcome.
Thank you so much for that, Dr. Moreno. And we just want to make a quick clarification as well. It is correct that Ferrocal is a resin-modified calcium silicate, not a ferric sulfate. So,
okay.
So we just wanted to share that with everybody.
Thank you. Sorry, I didn't hear properly.
Dr. Moreno. If you don't mind, just one more time sharing with us your email address. That way, whoever is interested to reach out to you privately can do that. So can you just read it out to us if you don't mind?
Mine is Dr. Moreno, DrMoreno at Boca, BOCA dental.ca. So Dr. Moreno at bocadental.ca.
Awesome. Thank you so much for that, Dr. Moreno.
Thank you so much. Thanks for inviting me.
Thank you. It's an absolute pleasure to have you.
I'm sorry that I went beyond and I'm going to have a bit of water and then wait for Dr. Mansur now.
All right. Perfect. Thank you so much.
Okay. Thank you.
I would like to introduce next our co-host for the day, Dr. Soni, to introduce our next speaker. And once again, thank you so much for the questions, Christina. And thank you, Dr. Moreno.